Welcome to the first of a series of monthly webinars hosted by the International Menopause Society. I am Nick Panay, General Secretary of the IMS, and I will be chairing this webinar on menopause hormone therapy prescribing, the do's and don'ts. This webinar is intended to act as a practical guide to the prescribing of MHT. There will be two presentations of the key issues, case studies, and an opportunity to ask questions. I'm delighted that we have two world-class speakers with us today. The first is Professor Rodney Baber from Sydney, Australia, past president of IMS, who will present an update on MHT prescribing principles and options. And the second is Mr. Tim Hillard from the UK, board member of IMS, who will present the do's and don'ts of prescribing MHT. Each speaker will have 15 minutes. There will then follow half an hour of questions and answers. Before we start, we would like to extend our gratitude on behalf of IMS to Bezan Healthcare for supporting our series of webinars through an unrestricted educational grant. I should emphasize that Bezan had no role in the selection of topics or speakers and have not reviewed the content of the speakers' presentations.
Thanks very much, Nick, and hello to everybody. Good evening from down under. I hope you're all wide awake on the Northern Hemisphere and enjoying the world and a bit of escape from lockdown. My task is to talk to you about MHT prescribing principles and options. And the topics I choose to cover today include the stages of reproductive aging, defining the perimenopause and the menopause, a little bit about the global consensus on the use of MHT, the benefits of MHT, contraindications to MHT use, the side effects, and then important things we need to consider when we engage our patient in what I would call the midlife women's health consultation. A few guidelines generally to prescribing MHT, and then we'll try and bring it all together with a case study at the end. You'll all recall that these are the stages of reproductive aging as were defined in the Straw Plus 10 workshop back in 2012. Basically, there are 6 phases before the last menstrual period, or FMP, and 4 following that. And what we want to discuss with you today are those areas outlined in the 2 red rectangles, which really define the perimenopause, the menopause transition, and the post-menopause. And you can come back to this at later times just to refer to it, as I will discuss it as we move forward. But the critical definitions for us to recall today are the perimenopause, which marks the beginning of the menopause transition and starts with menstrual irregularities of more than 7 days between consecutive cycles, over that last menstrual period, and then continuing for the next 12 months. It is after that 12-month period that the menopause is said to have occurred. The menopause is the permanent cessation of menstruation, occurring after 12 months from the last menstrual period, and it continues for the rest of a woman's life. And both perimenopausal and menopausal women may experience and seek treatment for a variety of symptoms which are related to estrogen deficiency. Quite often, by the time they get to you, they will have tried many things. But we know from research, from meta-analyses, from Cochrane systematic reviews, that the most effective treatment for menopausal symptoms is menopausal hormone therapy. Menopausal hormone therapy has been around for nearly 80 years, and it would be fair to say it's had its ups and downs. It's had good times and it's had some pretty bad times too, and many of you will remember the dramas associated with the Women's Health Initiative in its initial releases. But now we have a clear consensus agreed upon by experts from all over the world, and these are the key motherhood statements, if you like. The principal indication for MHT is the alleviation of troublesome vasomotor symptoms, but it should be part of an overall strategy aimed at improving midlife women's health. The dose and the duration of therapy should be consistent with your treatment goals. There is no mandatory stopping point. Estrogen only is appropriate therapy for women who have had a hysterectomy. But when the uterus is present, a progestogen must be added to provide endometrial protection. If symptoms are confined to the lower genital tract, topical MHT will often suffice. And unfortunately, current safety data do not support MHT use in breast cancer survivors. There are several benefits of MHT. Obviously, the most important one is that MHT will alleviate menopausal symptoms and will do so more effectively than any other intervention. The benefits are greatest and the risks are fewest when MHT is initiated within 10 years of the last period. So the time to initiate is when the symptoms are at their worst. MHT also reduces the risk of osteoporosis-related fractures at the hip, at the spine, and at other sites, and is equally as effective as other interventions which are available. Estrogen therapy may also decrease the risk of coronary heart disease when it's initiated within 10 years of the last period. The data on estrogen plus progestogens shows a similar but less compelling trend, and I believe that that is because many of the studies which have examined that association have used synthetic progestins. There are, of course, some contraindications to MHT. They include a known or suspected estrogen-dependent malignancy, undiagnosed PV bleeding, untreated endometrial hyperplasia, any current thromboembolic event or myocardial infarction, and acute disease, really, acute hypertension, active liver disease, and porphyria cutanea tarda. And there, of course, are potential side effects as well. The short-term side effects include fluid retention, bloating, headaches, and vaginal spotting and bleeding. And the long-term potential adverse effects include thromboembolic disease and breast cancer. The short-term adverse effects are almost exclusively related to dose and to the choice of regimen. I would strongly recommend that you commence with a low dose and titrate up if you need to alleviate further symptoms. If you do that, you will minimize the fluid retention, the headaches, and you will also minimize the vaginal spotting and bleeding. But it is also important for us to recognize and for our patients to understand that unexpected bleeding is not uncommon during the first 6 months of treatment. And it is not a sign that something terrible is happening. It's a sign that they should know that this is going to be something which will pass as time goes on, but must be investigated if it persists beyond 6 months. The long-term side effects are, of course, the ones which we are most concerned about, and they include thromboembolic risk, which is increased with oral therapy, but not with transdermal therapy. And secondly, breast cancer. And breast cancer risk appears to be related to the dose of hormones used, the duration of such therapy, and the choice of progestogen, with increasing information showing us that natural progestogens are more safe for the breast than synthetic progestins. And that brings me to the midlife consultation and really what we should consider. This data here is taken from the practitioner's toolkit, which I've referenced at the bottom of the slide. And you can see that whether a woman is perimenopausal or postmenopausal, this is a critical consultation and sets this woman up for healthy lifestyle moving forward. You must inquire about her personal and her family history. You must take a general health assessment. You must discuss lifestyle issues, including smoking, alcohol consumption, physical activity or lack thereof, diet, and BMI. And you should also discuss appropriate screening tests, such as mammography or cervical screening tests. It's important to remember contraception, If a woman's last period occurs before the age of 50, she should use contraception for 2 years. If it's after the age of 50, she should use contraception for 1 year. If she has a new partner, she should also be made aware of the need for safe sex. And of course, this is also the time to discuss the management of menopausal symptoms, of vulvovaginal atrophy or GSM, a topic which many women will not raise unless you discuss it with them. It's a time to inquire discreetly about sexual activity and whether she is having problems in that regard. And of course, to talk about prevention of long-term disease, such as osteoporosis and cardiovascular health. And if your patient decides that she would like to use hormone therapy and you think it's an appropriate intervention, then what you choose will depend on her stage going through the menopause transition and what she would prefer. If she's perimenopausal, you could use sequential estrogen plus progestin therapy. You could use the combined oral contraceptive if it's not contraindicated. And that is really the only option that is going to give this woman a combination of contraception, regulation of her cycle, and alleviation of symptoms. Or you could also use a levonorgestrel intrauterine device, which may well have been inserted to provide contraception or control of heavy menstrual bleeding in the perimenopause, and add estrogen as you need to. If she is postmenopausal and still has a uterus, you could use the combined transdermal estrogen and progestin patch, a transdermal estrogen, either patch or gel, plus oral progesterone or the levonorgestrel intrauterine device. You could use oral E plus oral P, or again the LNG-IUS, or you could use tibolone, or if it were available, the TSEC. But remember also, if a woman has had a hysterectomy, the only hormone she critically needs is estrogen, and she could use transdermal estrogen or oral estrogen. If she happened to have been using, say, tibolone or the TSEC prior to her hysterectomy and wished to continue, that would not be a contraindication. So let's take all of this and put it through a case presentation. This is a patient of mine, Annette. She's a married woman, she's a banker, she has 3 children, no comorbidities, and an intact uterus. Her physical examination is normal. Her BMI is 22, but she has vasomotor symptoms day and night. She has trouble sleeping, it's interfering with her work. She had irregular periods for 11 months, and she's had no periods for the last 8 months. Her family history is unremarkable. She's tried everything else there is, and she said to me, I just need hormones. And it's perimenopausal. The history in this case makes the diagnosis. We don't need to do any blood tests to prove this diagnosis. We should discuss appropriate screening, as I mentioned before, and we need to discuss contraception and lifestyle measures. She's keen to use hormones, and the options would be, as I mentioned a moment ago, sequential hormones, the IUS plus estrogen, or the combined pill. And she has no contraindications to any of those interventions and could be prescribed any one of them, or oral or transdermal therapy. As it turned out, she chose to use transdermal estrogen with oral progesterone for 14 days each month. That will give her a regular withdrawal bleed and minimize the risk of breakthrough bleeding. I told her she should have at least an annual review, but to come back sooner if she had any problems. She came back 6 months later. She was happy. She'd had no bleeding except for her monthly withdrawal bleeds, and she was getting sick of those. She's now postmenopausal by definition, as her last real period was more than a year ago. And she said to me she wanted to change to continuous combined MHT. I thought that was a fair thing. So we switched her to use transdermal patches and micronized progesterone capsules, which seemed like a good idea. But 7 months later, she rang me and said she'd had some unexpected PV bleeding. Annette's bleeding is beyond the range which we would say was reasonable and expected. This is unexpected bleeding, and you must order a transvaginal pelvic ultrasound on a patient in this situation to exclude endometrial thickening. Thankfully, on this occasion, an ultrasound done by an expert gynae ultrasound practice showed normal ovaries, a normal-sized anteverted uterus, and a nice thin 3mm endometrium. So I was able to reassure Annette that there was no evidence of endometrial hyperplasia, and I told her that she should come back to see me if she had a recurrence of her unexpected bleeding, but otherwise annually. I'm pleased to say I haven't seen her for the last 11 months. Further information on this can be obtained from the IMS website, from the Australasian Menopause Society website, and both of those websites also have information sheets which you can download for free and use for yourself for further information or also for your patients. Thanks very much, Nick.
Rod, thank you very much for that excellent presentation. So I would now like to move on to Tim Hillard's presentation, and then we will take questions. And can I remind people to use the chat button at the bottom of the screen to ask their questions. Please don't be shy.
Thanks, Nick. So I'm going to build on what Rod has been talking about by talking a bit more in detail about the do's and don'ts of prescribing. These are my disclosures. And the topics that I'm going to cover is really how to choose the right MHT, whether to use cyclic or continuous, and then selecting the right estrogen, the right progestogen, how to troubleshoot when things don't go well, and what we do about treatment review, and again, round that off with a case study that illustrates some of the points we've discussed. So the first thing is, as Rod has said, the most basic thing is to simply ask your patient whether or not they've had a hysterectomy. If they've had a hysterectomy, it's pretty simple. They need estrogen as the main form of treatment, and you can choose which option you want, which we'll come back to in a minute. If they have a uterus intact, then it's mandatory to consider using a progestogen, and the progestogen can be given either in the form of an intrauterine device or orally or as part of a patch combination, and you can choose the estrogen combination that goes with that. And again, we'll go through that in a bit more detail. But essentially, that is the basic starting point for any prescription of MHT. And only if you run into problems with that do you need to consider more complex things like implants, which are mentioned at the bottom. So looking at the different MHT regimens in a slightly different way, this helps to understand how you are going to build up your hormone replacement. So again, on the top, if they've had a hysterectomy, it's simply you give estrogen, which is in blue. If they're postmenopausal, then it's a no-bleed preparation, which is the preferred option, and that is a continuous estrogen and continuous progesterone. If you have somebody who's perimenopausal, then you need to be looking at giving them most likely a cyclical bleed combination with continuous estrogen and progesterone added for 12 to 14 days each month. You can look at a quarterly bleed option where your progesterone is given every 3 months, and this can be quite useful particularly for women who are struggling with the progesterone component of their treatment. But it is important to recognize that in this group, you can get irregular bleeding during this 2.5 months before the progesterone is added, and there is an increased risk of endometrial hyperplasia if this treatment is continued for any length of time. So it's certainly not a long-term option, but can be a useful shortish-term option. So if we look at the options for perimenopausal women, this is the group that really causes the most confusion. The options, as again Rod has highlighted, are to either give continuous estrogen and sequential progestogen. This is usually the best starting option for women over the age of 45. It's important to commence on the beginning of their natural cycle. So if they're still having a 28-day cycle, to start around day 1. And this will hopefully coincide the MHT cycle with their own natural cycle. MHT in the doses we use is not strong enough to override somebody's cycle. So if we start it randomly, you may well get irregular bleeding straight from the start. The trouble with this is it doesn't necessarily control premenstrual symptoms, but transdermal options are available, so you have got quite a lot of options to play with for this particular type of treatment. Contraception, combined contraceptive pill is also an option, particularly for the younger woman. One obviously has to review whether or not there are contraindications to the pill, but if there aren't and it's fit and healthy, then it is a reasonably good option for the younger woman. It gives good cycle control and it can control PMS symptoms, so can be attractive. There's an additional benefit, of course, of ongoing contraception as well. There are newer formulations available in many countries now, which are much lower dose, and some of them have 17-beta estradiol as the main component. So some of the potential risks associated with traditional contraceptives may be less than they were a few years ago. So it does remain an option, particularly for the younger woman. The continuous estrogen together with the levonorgestrel IUS is another excellent option, particularly if the woman already has a levonorgestrel IUS in for contraceptive or bleeding control. Then you just need to literally add in the estrogen and titrate the dose accordingly. The main advantage of this is it's no bleeding, or usually not much bleeding. It doesn't necessarily control PMS, but you can add an estrogen of your choice again. So you could use transdermal estrogen very nicely with this without any other problems. And finally, the option for continuous estrogen and continuous progesterone. Quite a lot of people ask for this at an early stage because perhaps they're fed up with their bleeding. But in fact, it's counterintuitive to actually start a continuous combined preparation in someone who's still having a cycle, because it's not usually strong enough to overcome the natural cycle. And often you end up with worse bleeding than when the patient started. And that can cause dissatisfaction with treatment and increased likelihood to discontinue and just getting fed up with it. But you can still find it suits some women. And again, it's down to the individual history, the age of the patient and where they are in their perimenopause as to whether that can be an option, but it's not usually a starting point. So for a few things to consider when we're starting to choose the right MHT, there are many packages that are available in predetermined doses and combinations, and we'll all have in our own countries different ones available, and you'll have your own favorites. And for most women, that's a perfectly reasonable starting point. But it is important to look closely at the components within those ones, because they do vary considerably, both in dose and type of estrogen and progesterone, as we'll see in a minute. Certainly, oral therapy is popular. It's very easy to use. Most patients know exactly what to do if you give them a tablet. Most of the packets have, it's very intuitive how to follow and take the tablets day by day, and it's very convenient. So for many women, it is a good option, and it's important to get them on board when you're trying to start a treatment to get them to continue with the treatment. Transdermal estradiol avoids the first pass effect and is certainly a preferred option for those who might have increased risk, particularly those increased risk of venous thromboembolism, such as those with a high BMI or some other factor that may increase their background risk. So certainly worth considering in those groups, but it's not essential for everybody. One of the downsides of the transdermal therapy is it's only really available in one strength. Although it is available cyclically and continuously, you don't have a huge amount of choice if you're just using a patch, but there are other ways around that, which I will demonstrate in a minute. So a good starting option is one of these fixed oral combined treatments that you may have your own favorite, and that's certainly reasonable as an initial starting point. But if you're running into problems with symptom control or side effects, then you need to look to break down the MHT into its constituent components. We look at the estrogen and the dose that you can choose, and you look at the progesterone, the dose, and then you mix and match. And this may mean writing two separate scripts to get the right balance, but it's important as a menopause specialist to be able to understand this and to work your way through it. So if we look first of all at the estrogen that are available in MHT products are listed here. There may be others in different countries, but these are basically the main ones that are available. They are 3 oral combinations and 2 transdermals. There are also different doses. These are roughly the sort of doses we would consider low, moderate, and high. So if you take an 17-beta estradiol tablet, we'd start with a 0.51 milligram tablet, and a 2 milligram is considered a high dose. There are patches at different strengths, and there's also gel which can be used. As Rod said, it's important when we're starting treatment to start with a low dose and build up gradually. Many of the risks and concerns and side effects with MHT are associated with dose. So if you start low and build up, then you're less likely to run into problems initially. And it's a good pharmacological principle to always stick with the lowest effective dose that you can manage. It's important to recognize that younger women often require higher doses, so that those women under the age of 45 may well require a higher dose, and it may be necessary to go above our recommended higher doses here for certain individual women, but that should only be done in consultation. Similarly, if you've got an older woman who's starting MHT, she may need a much lower dose, and you could start with one of these doses or even lower than this initially and build up very gradually. But if someone's not had estrogen for a number of years, then they may be more prone to getting side effects when you reintroduce estrogen. So it's important to start slowly. Another important point with low dose is to remember that there may not be enough to relieve the VVA symptoms. So additional vaginal estrogens may be needed on top of the standard systemic MHT. We will be discussing VVA symptoms more in the next webinar and one of the forthcoming webinars in August, and more details about that in due course. So having selected your estrogen, it's now important to look at the progesterone. And first of all, I'm going to start with the sequential progestogen. So these are the ones that are given for 14 days each month. Again, you will select your progesterone depending on either the individual product that you can prescribe or what's in the combined combination that you've got available. And again, majority of these are oral, although norethistron is available in the transdermal patches as well. These are the doses that we would normally recommend as the minimum dose if you're using with a low dose estrogen, and the higher the dose of estrogen, then you really ought to increase the dose of the progesterone correspondingly to make sure you get full cycle control and reduce the risk of endometrial hyperplasia. It's important to recognize that different progesterone groups have different side effect profiles. So the norethisterone norgestrol type group have certain side effect profiles, where digesterone and micronized progesterone may have different side effects. And just because a patient is getting side effects with one type of progesterone doesn't mean to say she'll get them with the other. So it's worth looking at the progesterone and, if necessary, changing the progesterone to find one that suits her better. If they have continuing problems, then you may be able to reduce the length of progesterone from 14 days down to 10 days a month, but need to be aware of the dosing and make sure that you're still getting good cycle control. Micronized progesterone is a good option, and for many women who ask for bioidentical hormones, it's important to highlight that this is equivalent to the progesterone that's produced in women. So it is essentially bioidentical, but it's important we stick with regulated products and not use compounded therapies. If you're looking at continuous progesterone, again, the same progesterones are available. And in addition, we have drospirenone available, which isn't available in a sequential combination. And also, of course, you've got the levonorgestrel intrauterine system, which can be prescribed at any age and gives good cycle control, as we've discussed before. For the continuous group, it's recommended for all women over the age of 54. And where we've also briefly discussed how we can start on that. The benefit of a continuous progesterone is it allows a lower dosage to be used, which reduces cyclical fluctuations, so that may reduce progesterone-related side effects. But the other side of the coin is you are taking progesterone every day, so some women will find that difficult to manage. Unfortunately, not all preparations are available in every country, so you may have to work with what you've got, but it's important, again, to try and understand what is available and what you could use within your own practice. So, some additional tips above and beyond that is that transdermal estrogen gel has a very flexible dosing options, because the patient can change the dose almost on a daily basis, but there has to be used with an oral or intrauterine progesterone. So it's important they understand that they need to use the progesterone continually, but they can use the gel and change the dose a little bit if you're finding trouble getting the right dose of estrogen. For those women who are particularly concerned about breast cancer risk, transdermal estrogen plus digesterone or micronized progesterone may be a better option. Digesterone seems to have less progesteronic side effects than some other progestogens in many women, and the data that we've got so far suggests that these progesterones have less impact on the breast cancer risk than the traditional norethisterone norgestrel based progestogens. So they may be an option, although these data are observational. The transdermal or oral estradiol plus the levonorgestrel IUS is a convenient no-bleed option. And again, in studies, it's been associated with some less breast density than oral norethisterone, which may be a positive factor in interpreting mammograms. But we haven't really got the data to say this is a safer option in terms of breast cancer risk. Finally, we do have tibolone as an option, which has very different characteristics to conventional MHT, and therefore can be an option in patients who are not getting on with other treatments, and it does have androgenic properties as well. And finally, the SERM, TSEC, with Premarin and basodoxifene, is now available in some countries, and it provides an alternative option for women, again, those who are postmenopausal. So having started on the patient on the treatment, it's important you have some policy within your departments for how you review these women. Usually it's recommended that this is done at around 6 to 8 weeks as an initial review to see if they're getting symptom relief, to check that they're not getting side effects and any particular queries or concerns that they may have. It's very important that that patients understand that they've got somewhere to come back to if they have concerns, because so often women start treatment if they have a problem and they don't know where to turn to, they will just stop taking it and not get the benefits longer term. So some form of review, whether it's with yourself or with a primary care physician or with a specialist nurse or whoever, is important to build into the initial pathway. And then once they're set up, a review again at around 6 months, and then again at 6 to 12 months. What we've found in our own practice in the last few months with the unfolding situation around the world is actually nearly all these consultations can be safely done over the telephone, and the number of visits one has to have to the hospital now are significantly reduced, and this is quite possibly a way that we can move forward in the future. So I'm just going to bring this together with a case history of a patient I saw recently. This is a 47-year-old lady who works in a supermarket. She's had 3 children, a partner's had a vasectomy, and she's up to date with her smears. She's basically fit and healthy, but she is a little overweight with a BMI of 30. She presents with severe vasomotor symptoms, which are disturbing her sleep. She flushes during the day. She finds it very embarrassing, and she gets very hot and sweaty, and she feels like she's going red when she's on the checkout counter, and she finds it very, very difficult and embarrassing when she's at work. On close questioning, she also reports classical symptoms of joint aches. She's got increased anxiety and mood changes, particularly in a few days before her period. She's still having a more or less regular cycle, though it's become a little bit erratic over the last 12 months or so, and the last period was 3 weeks ago. So the diagnosis based on her age and the symptoms that she's perimenopausal. We don't need to do any complicated tests to make the diagnosis. It's pretty obvious, as Rod said in his presentation, that this is a fairly straightforward diagnosis. Important to initially discuss lifestyle measures with her, and for her in particular, weight loss may be a key point, but it's not going to resolve all her symptoms. So it's important to then look at what the treatment options are. She's very keen to do something about it. She wants something to work quickly, and we've discussed the various options that are available, as we've just done now. She preferred the idea of taking a tablet. She didn't really like the idea of patches or gel, and was quite happy just to take a tablet because she knew what to do. So I started her on sequential estrogen and progesterone, standard preparation of 1 milligram of estradiol, 14 days of 1 milligram of norethistone, and advised her to start this on the first day of her next period, which was coming up fairly soon. And I was going to see her again in around 8 weeks' time. When she came back in 8 weeks, she said things had improved quite a lot. She'd certainly noticed an improvement in her hot flushes and night sweats, but they were still present, and she's still getting a lot of mood and anxiety problems. She also said that she'd noticed that she was getting bloating and headaches in the last 2 weeks of her packet when she was taking a different coloured pills, and this made her feel quite unwell and uncomfortable again, particularly when she was sitting down at her job. She wasn't very happy about that. So we discussed the various problems. She seems to have inadequate symptom control. She needs a higher dose of estrogen. She's got some progestogenic side effects, so we need to look at changing the progesterone. And on that basis, I put her up to a 2 milligram of estradiol tablet with a cyclical dydrogesterone combination, which is changing the progesterone, with a review in 3 months. In 3 months' time, she came back, reporting 100% improvement in her symptoms. Overall, all her other symptoms were better. Her side effects had disappeared. Her cycle control was good, and basically she was very happy with the treatment. So we agreed to review the situation in 6 months. 2 other things to consider with her. One is that transdermal estrogen might be an option to consider lowering her VTE risk, as she does have a slightly high BMI, but it's important to accept patient preference, and it's more important that she takes something she feels comfortable with than it is in trying to get the most pure treatment possible. And secondly, for her, with bleeding has continued to be a problem, the levonorgestrel IUS could be an option, but in her case, her partner's had a vasectomy, and contraception was not an issue. So for further information, again, as Rod said, the IMS website is available with downloadable information sheets. Also, the British Menopause Society website has a number of tools for clinicians which can be very useful and downloadable. There's a few references there, including the NICE guidance, which is referenced here. And finally, I mentioned about the IMPART, which is the IMS Professional Activity Refresher Training. This, some of you are familiar with IMPART and will have been involved with it before, but for those of you who aren't, this is a free educational tool. It's now being taken over by the IMS. So we're going to be running it from the 1st of July, and you will be able to log on and register, and there are 8 modules in all. And once you've completed all these modules, you will get a certificate of completion and complimentary introductory membership of the IMS for 1 year. You'll hear a lot more about that in due course from the IMS, but that's just to flag it up as a useful sort of source of information for the future. Thank you. Back to you, Nick.
Tim, thank you very much for a further excellent presentation. We have a very large number of questions, I'm delighted to say. Some of them are practical, some of them are a little more technical. So let's start with some practical ones first of all. Linda Haynes has asked about a perimenopausal woman, 51 years or over, not wanting the levonorgestrel intrauterine system, but still requiring contraception. She's wondering what the options are in that situation. Either of you can kick off with that.
Very nice. Well, I might as well kick off. Obviously, Linda, there's barrier methods for contraception. And as I alluded to in my talk, if she's just ditched her husband, she might, and has a new partner, she should certainly use barrier methods to provide some sort of safe sex. She could, there are UK medical eligibility criteria about the birth control pill, which say you can't use it over the age of 50 or something. But I think we have to take that on an individual patient basis. And if the patient has no underlying medical problems, nothing that we would consider to be a contraindication to the pill, such as, for example, migraines or hypertension or a history of thromboembolic disease, then the pill might provide her with a reasonable option for contraception, and at the same time would control her cycle and alleviate symptoms should they develop. And then, of course, the other options are permanent contraceptive measures, which you could discuss with her, including perhaps the possibility of, for example, a bilateral self-injectomy, which might also somewhat reduce her risk of ovarian cancer going forward. I'll give Tim the chance to talk about all the other options, Nick.
Tim, did you want to
just to
add
say
to that?
I think another, it's a very practical point, and I think one of the other things that you can consider is someone who's on the progesterone only pill, and particularly if they've tolerated it well in the past, is that you can consider continuing that with estrogen. I think that there is no data to absolutely be clear that that is protective, but depending on the age of the patient, and the closer they get to sort of 54, the natural risk of pregnancy gets lower and lower. So I think using a progesterone only pill in combination with a standard estrogen can be an option to consider as well.
We have a question from Manju Navani. In perimenopausal ladies on sequential hormone therapy, I mean, this has been mentioned in both the lectures already, but are there any top tips in terms of advising your patients as to the ideal time to switch over to continuous combined? Some women may want to try to achieve a no-bleed regimen earlier than others. So how do you strike the balance with your patients?
Shall I take that one?
Sure.
I would, again, it's very much individual. I think if they are going to try and sort of wing it a bit earlier, if you like, than 54, then they just need to be aware that there is a risk of irregular bleeding. It's important, again, depending on whereabouts in the world you are, you don't suddenly end up in a cancer pathway just because you've had an irregular bit of spotting, because that can often throw things out. So recognizing that it may cause a bit of irregular bleeding if you start that process, and be prepared to stick with it. there is no ideal time, but I think the more, as in Rod's case history, the longer the patient has had amenorrhea before you start, the more likely you are able to move quickly. If you've got someone who's still having a regular cycle when they start their MHT, then you're probably not going to win if you start switching them too early, and it can be a false economy.
Rod, anything further to add?
No, I agree entirely. I think, Tim, it's exactly right. My patient had had 8 months amenorrhea before she started sequential therapy, and then had 6 months of regular withdrawal bleeds. So I thought it was reasonable. But Tim's point is the key thing. The longer it is from her last normal menstrual period, the more likely it is that we will get away with complete amenorrhea. So it's a trade-off.
Totally agree. So the next two questions from Alice Duffy and Louise Newson are very similar, which is, what is the evidence for needing 200 milligrams of micronized progesterone when increasing the dose of estrogen, for instance, in a continuous combined regimen rather than just using 100? Tim, would you like to kick off on that? I believe you had something on your slide about that.
Yeah, I did. I mean, well, again, it's a bit of a trade-off. I mean, the doses are based on the recommended studies that are available. So if you have studies that show a certain dose of progesterone works, then it may be reasonable to think that a lower dose might work, but you cannot absolutely with confidence say that. And I think it's the difference between prescribing something exactly according to the book and then being a specialist and interpreting that in your own way. And I think we all do that in our clinical practice. We take the data and we have to look at that and based on the individual patient. But as a rule, those are the doses we would recommend that you would start with. But obviously, if you are an individual specialist, then you may choose to use a slightly different dose. But it's important that you recognize that there may be a slight trade-off with that in terms of a risk of irregular bleeding or possibly endometrial hyperplasia. And it's very unlikely, but should that end up with something untoward happening, you've got to be prepared to back up your stand and your position.
And do you monitor those patients on lower doses of progesterone by ultrasonography? Or do you base it on symptoms?
And I wouldn't monitor them with ultrasound, but I would keep them under review. I would not be as a specialist, wouldn't be discharging someone on a suboptimal dose of progesterone back to somewhere where I don't know how they're going to be monitored, if at all, in the future. And obviously, again, as Rod has highlighted, if they have irregular bleeding, that needs to be investigated. And
Elisa Pinhat has asked, is it okay to administer micronized progesterone vaginally?
Well, yeah, I mean, sorry, Rod, do you want to
go? You carry on, Tim.
You can use it vaginally. Again, I think there's some data to say you can use it vaginally. My preference is to continue using it orally as a routine. Again, in the same principle as we talked about with a lower dose, it can be an option that you can use, but there are some caveats associated with it. The patients just need to be aware that it's a little off-piste in that sense.
There's a nice question here. Can femoston be given in patients with a BMI of over 30 because dydrogesterone has a lower risk of VTE compared to others? And again, that's from Manju Navani.
I think this comes back to Tim's point about patient preference and patient selection. In somebody with a BMI of over 30, you would probably prefer to use transdermal therapy. But there is indeed a slightly low risk of thromboembolic disease associated with dydrogesterone, and that combination certainly has a low relative risk of causing thromboembolic disease. So it's low dose, and I wouldn't rule it out. I would try to encourage the patient to use transdermal therapy, but if her preference was for oral, I'd use it.
And Dr. Shaliga Bhatnagar has asked, which is better, either micronized progesterone or dydrogesterone?
Well, I don't know, Rod may have a different view on this. I prefer dydrogesterone if we could have it. In the UK, as you know, we don't have it available as a separate progesterone. I think micronized progesterone has been around for a very long time and in different forms. I think side effects with it can be greater than they are with dydrogesterone, but it's very much personal choice, and I don't think there's a right or wrong answer.
Okay.
No, I'd agree with that. I think that's a fair answer. We have good data on micronized progesterone in terms of its effect on the breast and on thromboembolic disease. We can't get dydrogesterone in Australia either, unfortunately, except with great difficulty. But it is a very good oral option, and obviously we can give it in much lower doses.
Corinna Niamatu says, thank you for the excellent presentations. What about MHT for women with personal history of endometriosis? In fact, we've had a couple of those questions. And also, she qualifies it with or without a uterus, so even after hysterectomy.
Tim?
I think without the uterus is an easier one to answer, because with the uterus you'd definitely be giving progesterone anyway. The key question really with endometriosis is whether or not, if they've had a hysterectomy, you need to add in progestogen. It depends a little on the background, the severity of the endometriosis. If it was severe endometriosis that was removed, then I personally would recommend a progestogen for a few years afterwards. Again, it's a trade-off, because obviously you're getting slightly increased risk of potentially breast cancer by taking the progesterone, perhaps over a few years, but you're probably stopping the resurgence of any residual endometriosis tissue that might be present if you just give estrogen alone. So it's a bit of a trade-off, but I would prefer generally to give a progesterone in those situations for the first few years. On the other hand, it's quite instructive sometimes if you look at get hold of the patient notes if you can, and look back and just when the patient says they've had terrible endometriosis, and you read the operating note that said they had one spot of endometriosis. So if it's very mild endometriosis, probably you don't need to do it. Depends on the severity.
Yep,
Rod,
I agree.
question?
I agree, Nick. My practice is usually, certainly endometriosis or a history thereof is not a contraindication to MHT. And in somebody who's had a hysterectomy, I would normally give them combined estrogen and progestin therapy for the first couple of years. And if they've had no recurrence at that stage, I would probably switch them over to transdermal if I could, estrogen only.
And as always, we would welcome further data on this.
We sure would.
Yeah.
Okay, let's see. There's one here from Alice Duffy. In a woman on sequential hormone therapy who has a transvaginal ultrasound after her withdrawal bleed, what is the upper limit of endometrial thickness that should be considered as being normal? I guess what she's getting at, should we be using the 4 or 5 millimeter cutoffs that we use for postmenopausal bleeding?
Well, I'd say, why did you do the ultrasound if she'd had a regular withdrawal bleed? That, I guess, would be my first question. The answer probably is that she had abdominal pain and somebody ordered an ultrasound. I don't think we have any data, but I would expect the endometrium to be thin after a withdrawal bleed and then to increase as the estrogen-only phase of the cycle went on. So my practice would be to do a scan, as I would do in a perimenopausal woman, in the first 6 days after she'd had a bleed, and I'd expect the endometrium to be 6 millimeters or less.
Yeah, I think the point I would add, and as I mentioned in my presentation, I think that it is somewhat frustrating when these scan results get interpreted as if it's a postmenopausal bleed, because it sends them down a completely different pathway and it frightens the life out of them, and often they end up seeing people who don't actually understand about hormone MHT, and they get stopped all the symptoms return. So again, I wouldn't usually do a scan, or if I did, I'd be cautious about interpreting in those situations, and I certainly wouldn't use a postmenopausal bleed cutoff. I think if you get a result that comes back and it's, say, 7 or 8 millimeters, then you might want to repeat the scan immediately after a bleed, as Rod suggested, if you're concerned. But I would interpret it loosely, and I wouldn't be applying the same criteria as you would if someone is clearly postmenopausal, then has a bleed at that stage.
So we had a couple of questions about tibolone, and I noticed that you recommended tibolone as an option with and without hysterectomy. But with hysterectomy, are you not getting an unwanted progestogenic effect? So what would be the indication for using tibolone post-hysterectomy?
For me, it would be if the patient, for example, had suffered from mastalgia with other forms of hormone therapy and had found the tibolone was very satisfactory. For people who had particularly dense breasts, because I know tibolone is not going to change their breast density, they would probably be my main indications. But I also work on the if it isn't broken, don't fix it theory. And so if I had a patient who had been on tibolone and very happy, but had then had a hysterectomy for some other reason, then I wouldn't automatically just change her to estrogen.
I would agree with that, and the additional benefit tibolone may have is on libido, so that can be another consideration. But we'll obviously discuss that more in the next webinar next month.
So we're going to get a little bit more technical now and very topical, I think. Professor Sunila Kandawal, who you may be familiar with, is one of our esteemed board members of the International Menopause Society. Use of MHT in times of COVID, special precautions in treatment and instructions to patient in the context of VTE risk. Clearly, we don't have data on that, but what would be your views on that situation where somebody potentially has a higher VTE risk? We know that COVID has a vascular effect. Should we be cautious in that situation?
My view would be if you were going to have a patient who you're concerned about, you'd be using transdermal therapy anyway. There's pretty convincing observational data to show that VTE risk is not increased beyond baseline if we choose to use transdermal estrogen and say dihydrogesterone or micronized progesterone. So I would be focusing more on other measures to reduce that individual woman's risk of thromboembolic disease. For example, getting a bit of exercise if she could, making sure that she didn't put on unnecessary weight, watching her diet, giving up smoking, all those things. If you put all those other incidental lifestyle factors, many of those will reduce the risk of VTE more than any form of hormone therapy can possibly increase it.
Tim, any comments?
Yeah, well, I think those are all valid, very, very valid points. I mean, I think the other thing I certainly wouldn't recommend she stops the treatment because of the current situation. There is some limited suggestion, I know there's ongoing trials looking at it, about whether estrogen may have some protective effect against COVID. We don't know the answer to that yet, but there's some speculation of that. But the other factor which I think is important is being able to have access to appropriate care, because certainly even in the UK and some during the height of the pandemic for us, meant a lot of normal services were stopped, and therefore getting diagnostic help or getting even specialist advice has been quite difficult. So I think there is an element of being able to try and safeguard looking after your women when the situation is at its most critical and that other services are stretched. And how you do that, that's very much a big challenge for all of us, but it's going to be very much down to local structures.
I had a patient who, during the height of the COVID pandemic, insisted on having a menopause consultation, because she said, well, if I'm feeling hot and sweaty, how do I know it's not COVID? So if you treat my hot flushes, then at least I can stop worrying.
Did it work?
Yes.
Very much so. She was a new woman. So we have a question from Lee Shawman. Good morning, everyone. What about hormone therapy for women with triple negative breast cancer? And perhaps we could take that in the sort of wider context of what we feel about women who perhaps do have a higher risk or past history of breast cancer, but have intractable symptoms. Do you have patients like that you would give off-label MHT to?
Yeah,
wow,
that's correct. I think these are the most difficult women to treat. They have many of them have terrible symptoms, and the options that we have to treat them at present are suboptimal. They're mostly off-label options, and none of them alleviate vasomotor symptoms as effectively as hormone therapy. I'd like to say, I'm just wondering if Lee is going to send us another message saying, by the way, I'm doing research on a neurokinin 3 receptor blocker or something like that. It'd be lovely to have those molecules, but at present my policy is to say to patients, we should look at lifestyle measures and things like cognitive behavioral therapy to try to alleviate your symptoms. We have a range of pharmaceutical options that we can offer you. But if all of those things fail and you really have intractable symptoms that are seriously affecting your quality of life, then you and I and your oncologist and your surgeon should sit down and talk about giving you some low-dose hormone.
And in fact, we have a question from Rock Zoo, who also asks about endometrial and ovarian cancer survivors and treating those with hormone therapy. And again, a difficult situation, Tim.
Yeah, I mean, I think the most important thing is to have an honest conversation with the woman about what the risks are. There is no easy trade-off. I think ovarian cancer is perhaps a little different because in general terms, ovarian cancer, there is no huge increase in risk associated with it. So it'd be a reasonable thing to do unless it's an endometrioid type cancer. But for most of the cancers, I think that's fairly straightforward. But for endometrial cancer and for the triple negative breast cancer, again, one has to be very cautious, try and look at all the options one can think of, which are going to be realistic. But if the patient is left with debilitating quality of life symptoms, as some of them are, then I think, you know, these are not, prescribing MHT off-label is not out of the question at all. You'd go for one of the options that seems to have the lowest potential risk and at a low dose and keep them under close surveillance.
Then we've got a couple of questions on managing risks in patients who require MHT. Juan Orellano has asked, what is the appropriate hormone therapy in a diabetic perimenopausal woman? Would you like to refer to that?
Again, it depends on the background scenario, but I think in general terms, probably the transdermal therapy is going to be a better option. Not all diabetic women have a high BMI, but some of them do, and therefore that's an increased VTE risk. So first of all, you're going to be looking at keeping that risk to a minimum. The impact of the different estrogens and progestogens on blood sugar control can vary. In general terms, transdermal therapy seems to have less of an impact than oral therapy. So I think in preference, I would use a transdermal therapy, but be aware that, again, this can be a little bit idiosyncratic. Some patients will respond in different ways than you expect. So you just need to keep an eye on their blood sugar control.
Which often does improve if you get the hormone therapy right.
You can do.
Yeah, that's right. I agree with that. I think Tim's right, but the critical point is the one you made, Nick, which is that generally speaking, insulin resistance will slightly improve with estrogen therapy.
We've got hundreds of questions coming in and a very limited time, unfortunately. There's one here from Chi Yu from China. Hello. My question is, what will be the choice of MHT for carotid plaque was found? So somebody with arterial disease, how would you go about treating them, if at all?
A good question, if at all. I think, can I just do this in 2 points? First of all, Chi, the best data we have really is still Michael Adams' data, I think, on the macaque monkeys, which showed very clearly that estrogen reduced the progression of plaque, that synthetic progestins attenuated that benefit, and that micronized progesterone did not attenuate the benefit. But I think for somebody who has pre-existing cardiovascular disease, they're very difficult patients to treat. And you would not, I think, treat with estrogens or progestogens at all unless you had run out of options. And then I would use the lowest dose transdermal therapy that I could, and I would stick to body identical hormones.
Anything further to add on that, Tim?
I agree. I think if you found that they got a plaque, then the first question is they probably shouldn't be. You'd be looking at why they got the plaque before that you add in MHT and deal with that first.
And I think we'll just finish on the question that many people have asked and many people ask all the time, which is about duration of use. The recommendations now that we don't put arbitrary limits on duration of use. Perhaps both of you could give a little potted summary, if you like, of how you approach the duration question with your patients.
You can go first, Tim.
Okay, well, look, I mean, the first thing is when patients start on MHT, you don't tell them it's for a set length of time, it's for as long as they need it, but then equally reassure them they don't have to take it for life. Some women are quite worried about having to take it for long periods of time, so it's really about getting them over usually what is a difficult time in their life, and that may be, for most women, maybe 2, 3, 4, 5 years before, and by then things settle down. So for the majority of women, symptoms will subside in that time, but there's absolutely no reason why they should stop it if they're getting ongoing benefit just when they reach a certain age. And so there's no time point, but I would recommend reviewing it at around the age of 60 to see what the evidence is at that stage, because it will obviously change over the coming years, what their own personal situation is, and often whether they need to change the dosing or the combination of the regimen they're on, depending on their own circumstances.
Yeah, that's a very nice summary, and I agree. My pet bugbear is people telling me they've had to stop because they've been taking it for 5 years. So I would strongly support Tim's point that we don't tell them that there is a stopping point. My own practice is to suggest to patients that the best thing to do is to start with a low dose, to titrate up as we need to alleviate the symptoms, that I will see or talk to her regularly for the first even 6 months of treatment. And then on an annual basis, she should come back for review. And my practice is to suggest to her that she tries coming off or reducing the dose of the hormones for a few weeks before she comes back to me, so that we can assess whether or not she can manage on a lower dose, needs a different regimen, needs to go back to the higher dose, or can stop altogether.
Well, thank you very much. Both very sensible advice there, and I think that reflects our current IMS recommendations. I'd like to thank Rod and Tim for their participation and for fielding the questions, as well as their excellent presentations. And if we could now move on to the next slide, please. As well as thanking our speakers, I would also like to thank Bezan for their support of the webinar. I'd like to thank BT Congress for their technical and administrative expertise. I'd like to thank you, our attendees, for your participation. I would also like you to register for the Impart course, because we think it's a very well acclaimed course, and we think that the 12 months free membership will enable you to become part of the IMS family, and we'd like you to continue indefinitely with that, of course. And we'd also like you to save the date for the next webinar, where the topics will be clinical lessons to be learned from the global consensus on testosterone for women. Our moderator will be Professor Tommaso Simoncini, and we will have, I'm sure, excellent presentations from Professor Susan Davis, current president of the IMS from Melbourne, on testosterone for women. Does it work and is it safe? And Professor Johannes Bitzer, what do you say when your patient tells you they have lost interest in sex? And the final slide, please. And finally, a very warm invitation to our next IMS World Congress, which will be hosted by Professor Susan Davis in the wonderful city of Melbourne. Please do go to the website, where you will see further details of the meeting, and we look forward to seeing you all there, hopefully in the not too distant future. So thank you very much once again for everyone, for your attention, for your excellent questions, and we look forward to having you present at our next webinar. Bye-bye.
Bye.